There are a number of risk factors for coronary heart disease. It's a more complex condition, perhaps, than people give it credit for. Um, a lot of people tend to think about coronary heart disease as being fat in the arteries. That's probably how a lot of people describe it. And sure, part of what's causing the problem in the arteries is related to fat. Um, but the process of how that gets there and how the narrowing happens is way more complex than just related to fat. So if we think about what coronary artery disease is, the heart is a pump. It is a muscle that squeezes and pumps blood around the body, and in order to be able to function, it needs its own energy supply. So it needs a blood supply to carry oxygen and nutrients to that muscle pump. And that's what the coronary arteries do. So they are the fuel supply to the heart. Um, any limitation to the flow in those coronary arteries will potentially limit the ability for the heart to do its job properly. And limitation in the flow in the arteries is usually due to some narrowing or blockage within the arteries. So the arteries act as a pipe delivering blood to the heart muscle. And if there's congestion in that pipe with any blockage or narrowing, then the flow may not be adequate. Now, that narrowing process is due to what's called atherosclerosis. So that's the change in the wall of the artery that leads to development of narrowing. So coronary heart disease is a manifestation of atherosclerosis, which can affect other parts of the body. People can have circulation problems in their feet or in their head. But when it affects the heart, that's what we call coronary artery disease or coronary heart disease. Um, so atherosclerosis is basically where the wall of the artery changes from being thin and very elastic, as it is when we are children, to becoming a much sort of stiffer, thicker wall, which actually happens to a greater or lesser degree in pretty much all adults as we get older. So it can be thought of as an aging process, but the speed at which that artery ages or becomes atherosclerotic will vary from person to person, and different factors will alter that the timing of onset. So there were studies a long time ago from American soldiers that were in the Vietnam War as young as late teenagers, and they had early changes of atherosclerosis. So it's a process that starts really in young adulthood or late childhood. And it can be very slowly progressive and not cause us any problems at all through most of our life or even all our life, or it can start to cause problems. So, what changes the speed or the likelihood of it happening are the risk factors that we're alluding to there. Um, so, I would tend to break them down as to into the components of how they cause the problem. So atherosclerosis is essentially a result of wear and tear or aging on the arteries. So anything that causes trauma or injury to the artery wall will accelerate the wear and tear. So directly injurious mechanisms, high blood pressure. So if your blood pressure is higher than it should be, you're putting more force into the artery wall and you may cause some injury that way. But even more important, because it's an easier thing to change, is cigarette smoking. So cigarette smoking, there are a number of chemicals in tobacco that are directly injurious to the blood vessel wall. So it accelerates the process of atherosclerosis, which is why smokers get heart disease at a younger age than non-smokers. Um, so you have factors like that sort of injure the vessel wall. Then you have a response to that injury, which normally involves your inflammation cells coming to try and heal and repair that injury. Um, and the inflammation cells are what tend to bring the fat into the vessel wall. So these cells called macrophages are often quite rich in lipids in fat. So if your immunity responds in a different way, so people with diabetes often have a very different immune response in their blood vessels, that will change your atherosclerosis. But also, if your fat levels are high, particularly cholesterol, there's another type of fat called lipoprotein little a, different types of fats that can be carried into the blood vessel wall by the inflammatory response to injury. And then after the blood cells, the inflammatory cells have died off from trying to heal this, the fat is left behind there in the artery. So you have this injury, then you have a response to the injury, then fat is brought in as well. The inflammation leads to scarring, and you get tissues like collagen, which is a repair tissue of the body, and smooth muscle cells, which are the cells that normally line the arteries, can become quite overgrown in response to the inflammation. So the actual atherosclerosis is all of these things. There's inflammation cells, there's fat, there's smooth muscle cell proliferation. All of these things are in the wall of the artery that used to be, when we were young, thin and elastic. And now it's not thin anymore because you've put all this stuff in there. Now, how that then develops in the arteries can be very different. So some people can have a very mild amount of narrowing, but spread over a lot of arteries. Other people can have all of that change just in very localized areas, which might actually cause more problems because it might be much more in one spot. So you get a narrowing in that spot, and the rest of the arteries might be fairly clear. And very little is understood about why certain areas are affected in certain people and not in others. So when it comes to risk factors, there are lots we don't know. So if I break that back down, we've got things that cause wear and tear. So that's getting older, cigarette smoking, high blood pressure. We've got things that affect your immune response to injury. So that's things like diabetes. Inflammatory disorders like rheumatoid arthritis can accelerate atherosclerosis. We've got the stuff that gets brought in by the inflammatory cells, which is the fat. So high fat, high cholesterol. And then a huge factor is genetics. So all of those things, blood pressure, response to injury, cholesterol level, they're all determined by different genetic factors. So family history is a big factor, but it's not inherited as a one-to-one thing like a gene for heart disease. It's many genes for all of these different factors. So a complex, what we call polygenetic inherited tendency. And then other things, unhealthy lifestyles. So if you're obese and not exercising, then you are more likely to have conditions like diabetes and high blood pressure, so more likely to get atherosclerosis. And your cardiovascular fitness is likely to be less good, so you're more likely to develop symptoms related to your heart. Um, and then another genetic factor is being a man. So men get heart disease at a younger age than women, and that's likely to be due to hormonal effects, protective hormonal effects of estrogens compared to testosterone and androgen hormones that men have. So loads and loads and loads. So it's a very long answer, but loads and loads of different risk factors for developing coronary heart disease that for an individual, they may be present, they may all be present, or very few of them may be present, and yet we still see quite a variation. So we see some people where there's no clear reason why they've got heart disease, and that's probably very genetic based. And then we see other people with loads and loads and loads of risk factors who may not develop heart disease at all. So it's a complex factor, but those are all factors that increase the likelihood of getting coronary heart disease. So there are clearly certain things that we can't change in terms of those risk factors for coronary heart disease. So getting older is something we all would like to do, and therefore we don't want to change that. Being a man, you don't. Most people don't want to change that. So there's a lot of things that we can't change. But there are things that we can change. So smoking, that's a lifestyle choice. Obesity, well, there's a large genetic component to that, but exercise and food intake and different types of food intake can influence that. Blood pressure can be lowered through exercise and more healthy eating. Diabetes can be improved by change of diet to a lower carbohydrate, lower sugar diet. So all these different factors, yes, there's lifestyle changes. So in simple terms, it's what you put in and what you put out. So what you put in is the food that you eat, and the foodstuffs that are harmful and more likely to lead to heart disease are high sugar or refined carbohydrates. So things that give you a rapid peaks of glucose in the bloodstream, but also foodstuffs that are are converted in the body to the harmful types of fats. So like they can get converted to LDL cholesterol or lipoprotein little a. So these tend to be things like saturated fats. So red meat fats, so bacon, pork, beef fats, and dairy fats. So cheese, full fat milk, these sorts of things. They are more likely to get converted to harmful fats than other things. So things like olive oil, less likely to do that. Fish oil, less likely to do that. And also the trans fats that you hear about that I think are probably less prevalent now than they were 10, 15 years ago in food, but trans fats are also potentially quite harmful. So there's the diet that you take in, there's the amount of calories that you take in. So it depends on how much exercise you do, and I guess your genetic predisposition to different things. But if you are eating a high calorie diet, then you need to be doing a lot of physical exercise to burn that off. Otherwise, it'll get converted to fat, and that will lead to various problems related to coronary artery disease in time. Um, so being aware, I think it's not about having crazy diets, but being aware of the harmful food substances, being aware of not eating more than your daily requirement for calories, and being aware that if whatever you're eating, you need to be matching that with a sensible level of physical activity to avoid weight gain that can then lead to heart trouble, blood pressure trouble, diabetes, and things like that. So fruit and vegetables are the simplest thing to recommend. Fruit and veg contain very little harmful ingredients and have the advantage that they contain quite a lot of water. So you fill your stomach up with what is food, but actually a lot of that food is water, and so you're taking in proportionately less energy, calories, and fats that way. So a simple thing is for people to just double the amount of vegetables, to be honest, that they put on their plate, and try and reduce some of the other stuff off the plate, the rice and the pasta and the meat. Um, and then the Mediterranean diet, which is largely based on sort of fresh fish and fresh vegetables, is proven by not just to observe, but proven in clinical trials to reduce cardiovascular disease through those same mechanisms. And it's basically displacing all the unhealthy stuff that probably North Americans and Northern Europeans have a habit of taking in, and replacing it with a slightly healthier diet that traditionally people eat in the Mediterranean. So Mediterranean diet, healthy diet, not smoking, so not doing things that are directly harmful, ensuring that you exercise and keep your heart fit, and your weight, prevent your weight from going up, keep your blood pressure under control. Those are the main lifestyle factors in preventing heart disease. So coronary heart disease, it can present with a whole number of different symptoms or none. So as I said, coronary artery disease is atherosclerosis in the artery wall, and as I mentioned, even young people, young adults often have some early changes. Now, if your changes in your arteries are not causing significant narrowing, you probably won't get any symptoms at all. When they start to cause narrowing in the arteries, that reduces the flow to the heart muscle, and the heart muscle can't get the energy and the oxygen it requires. So that's often when you start to get symptoms. And the classic symptom is what's called angina. Angina is a sensation of discomfort, typically felt as a sort of constricting feeling or a pressure in the chest. Sometimes people experience it in the jaw, sometimes people experience it in the neck or the shoulder, and that's due to what we call referred pain, which is the fact that deep organs like the heart or the bowels, the nerves that supply those may supply the skin in other areas not directly overlying those. So when people perceive the area of pain, they may be fooled into thinking the pain's coming from a shoulder area, when actually the source is something deep in the chest, like the heart or the stomach or the gullet. So it can be in different areas around the chest, but in an individual, it tends to happen in the same place. So if somebody's having chest pain that one day is in the middle of the chest, and the next day it's at the back of the chest, the next day it's in the jaw, It's less likely to be cardiac because it's moving about, but one person might always get it in the jaw, one other person might always get it in the chest, and that's what we have to be aware of. But it's often a constricting, pressure, achy kind of feeling, and it typically happens when the heart is doing activity because at rest your heart's demanding less blood flow. It can cope with narrowings in the arteries. As you exercise, it needs that blood flow, and it can't increase the blood flow like it needs to, and that's when it starts to give these symptoms, these sort of symptoms of angina that mean, look, I'm struggling to do what you're asking me to do. Please slow down. Please ease off. So that's the classic symptom of coronary artery disease, angina. Um, However, that does rely on the being able to sense pain and sense discomfort, and different people have different pain thresholds. Diabetics, we've mentioned, are more likely to get heart disease, but they also have neuropathy, which means their nerves don't work as well. So diabetics may paradoxically be less aware of those sensations in their chest and might just notice that they physically can't exercise as well, and they're not quite sure what's making them feel they need to stop because they're not sensing the pain as much. They might perceive it more as a shortness of breath or a fatigue. Um, then the heart can do other things. The shortage of blood supply can lead to other problems. It can lead to a weakness in the heart muscle, which could lead to fluid retention and shortness of breath. It can promote abnormal heart rhythms, which could lead to palpitations or a sensation of the heart beating abnormally or dizziness. Um, so these are all different ways that the atherosclerotic narrowing can present. The final thing, the most serious thing, is a heart attack. And a heart attack happens when the artery becomes fully blocked, and so there's no blood supply to an area of the heart. And that doesn't usually happen due to that narrowing getting gradually more narrow. What usually happens is that the narrowing has developed to a certain level, and it may not be that severe, but you get an injury again. I mentioned a lot to do with injury. You get an injury again to that wall of the artery that exposes all of that fatty tissue and collagen to the bloodstream, and you get a blood clot that forms very rapidly on that narrowing. So you can go from having a narrowing that might not be very narrow to a complete blockage because the blood clot sticks against this injured area of plaque. It's what we call a vulnerable plaque or a ruptured plaque. And that leads to sudden blockage of the heart artery that can lead to sudden onset chest pain, similar to angina, but more severe and happening without physical exertion. And that can lead to all sorts of problems. It can lead to dropping down dead with a cardiac arrest, or it can lead to severe chest pain that goes on to cause breathlessness and heart failure and a number of long-term conditions. So in summary, coronary heart disease can present gradually with a number of different symptoms. Classically, though, exertional angina, or it can present suddenly due to thrombus blood clot forming in the artery that will trigger a heart attack and the much more severe consequences of that. Okay, so actually probably the best test for detecting coronary heart disease is a CT scan. And that's because coronary heart disease is a descriptive term meaning that there is a problem with the arteries of the heart, the coronary arteries, and that problem is usually atherosclerotic plaque. And CT is a high resolution imaging test to look at anatomy and look at structures. So it's a very good way of looking at those arteries to see, is there atherosclerotic plaque, and is it causing narrowing? Um, but a CT is not always straightforward because your heart is moving, pumping, and to see the arteries clearly, you want to avoid too much blurring. So you need to have what's called a gated CT, which is where the ECG is monitored at the same time so that the pictures are taken at a particular time in the cardiac cycle. And ideally, you want to slow the heart rate down so that you can get less blurred pictures and capture the images more accurately. So they need to be done in specialist units. So not all CT units do cardiac CT. So it needs the ECG monitoring and often needs medications like beta blockers that slow the heart down to improve the imaging. So that's the best test in terms of is there coronary artery disease. I don't think there's any better test for that. But the question is often not is there coronary artery disease or not. It might be is the coronary artery disease causing a problem with the blood flow. Because, as I say, you can live with coronary artery disease and it doesn't necessarily cause you any symptoms. And the symptoms tend to happen due to blood flow. So there are different tests looking at the effect on blood flow. And these range from simple tests like an ECG, where we put electrical leads on the chest to get a little graph of the heart's electrical activity. And sometimes, particularly during pain, the ECG can show us changes that relate to circulation problems in the heart. There's an exercise ECG, which is basically where we get someone to walk on a treadmill in a very graded fashion of increasing effort. And we monitor the heart rate and the blood pressure and the ECG. And what we're trying to do is see when we put the heart under physical activity, physical strain, do we start to see some of those ECG changes that can reflect problems with blood flow to the heart? There's a test called a stress echo, which is similar to doing an exercise ECG, but with an ultrasound as well to try and look for changes in the way the heart is moving and pumping on exercise. And there's another test called a nuclear perfusion scan, which gives a radioisotope into the bloodstream that's taken up by heart muscle, and we compare that uptake at rest in normal circumstances against when we give a drug to increase blood flow to the heart, and we're looking to see does the blood flow increase normally and symmetrically through the heart. So those tests are looking for what we call ischemia, which is basically a lack or a reduction of blood flow to the heart, which is what the coronary heart disease tends to cause that leads to problems. Whereas the CT scan is looking much more at the disease itself and the narrowings. And sometimes we may want both tests to tell us what we want to know. Finally, the most invasive test, similar to CT but more invasive, is what's called a diagnostic coronary angiogram or an invasive coronary angiogram. And in that, we're using standard X-ray pictures, but putting the contrast that shows up on X-ray into the bloodstream directly into the coronary arteries, not into the whole body like we do in CT. Invasive angiography has the advantage that it's slightly higher resolution for the arteries, so we can sort of tell the difference between the amount of narrowing with slightly more certainty that you can on the CT. But it has the disadvantage that we only see where the blood would flow in the arteries. We don't see the outer wall of the arteries. CT can sort of see both. So if you have mild generalized atherosclerosis throughout an artery, you might not see that on an angiogram, invasive, because you just see what looks like a tubular artery and you don't know that it should be that big. It's just that big all the way along. For invasive angiography, you almost need a normal segment and a narrowed segment to see that there's a narrowing. Whereas CT shows the outside and the inside, so you can see definitely is there plaque or is there no plaque. It's much better at angiography at picking up the mild plaque. But where CT sometimes falls down is in telling the difference between yes, it's a bit narrow and yes, it's severely narrow. And that's to do with the resolution of the scan, but also calcium, which is commonly laid down in atherosclerotic plaques, particularly when they've been there for a while. Calcium makes X-rays bounce off. So CT is using X-rays and you get this bouncing off of the X-rays. So you get what's called a bloom artifact, which means they can see the plaque, it's definitely there, and they can see the calcium, that's definitely there. But there's all this reflection coming off the calcium that makes them sort of say, well, we can't therefore tell how narrow the artery is. We just know there's a significant plaque, but we don't know how narrow it is. Whereas an angiogram where we put in the dye into the arteries is much better at showing, yes, here's the flow down that artery. So there are all these different tests for coronary artery disease, but CT, I would say, is now the best test to see is there coronary artery disease present, yes or no. And then those other tests and angiography are more about refining, is that coronary artery disease causing a problem with the flow to the heart, and does anything need to be done other than just preventative type medications? Well, the treatment options for coronary heart disease depend on how, at the present time, the coronary heart disease is affecting the individual person. So we think about the process. Atherosclerosis in the arteries is the process. The really the only medications that are definitely proven to sort of halt atherosclerosis and prevent it from getting worse are the statins. So these are a class of drugs like atorvastatin, rosuvastatin, simvastatin, a class of drugs that affect the way that your own liver synthesizes cholesterol. So most of the cholesterol in our blood is not from cholesterol in food. It's manufactured by our liver in response to our genetic makeup, but also our dietary intake of fats like saturated fats and trans fats. And so statins affect the way your liver produces cholesterol, reduces the amount of the harmful cholesterol, LDL, and therefore reduces the sort of progression of atherosclerotic plaques. There's excellent evidence that they reduce heart attacks, they reduce strokes, and in people who have had heart attacks and strokes, they actually prevent or reduce the death rate from those conditions. So statins are massively effective. And yet they get a really bad press in the UK. People saying, "Oh, I've heard that statins can do this and do that," and it's like, well, yes, like any drug can have a side effect, but I cannot think of another drug in the world of heart disease that has as much evidence for helping and preventing and saving lives, and it's the only drug that actually works on the atherosclerosis itself that is licensed. So, statins absolutely the best treatment for anyone with coronary heart disease. And if someone takes a statin and has a side effect, try a different statin because they're all quite different. And there are genuinely people who can't take any, but most people can take one or another and will reduce their risk. So statins, big gold star. Other treatments, it depends what's going on. So if somebody's blood pressure is high, then medications keep the blood pressure down to prevent the atherosclerosis from getting worse. If someone has chest pain, the angina symptoms on exercise, then there are medications that can improve that. So beta blockers, I mentioned before, they work largely by reducing the heart rate and the heart rate on exercise. So your heart's working less hard, demanding less blood supply, so you can tolerate narrowings better. There are other drugs, amlodipine, which is a vasodilating drug, can lower blood pressure and slightly open the arteries a little wider. They don't get rid of the plaques, but they just improve the width of that artery a little bit. Nitrates, so things like isosorbide mononitrate or GTN spray, also work by doing a bit of vasodilatation, but they also dilate the veins, which is quite helpful because that means the heart has less volume of blood flow coming back to it, so less what we call preload, so less blood that it has to pump each time. So these drugs are very good at reducing the workload of the heart. So the statins are good at preventing the progression of the plaques and the underlying cause, whereas things like beta blockers, nitrates, amlodipine are reducing the amount of work that the heart is having to do, and thereby improving people's tolerance of living with the atherosclerosis. Beyond those medications, the question is then, do you need to do anything to the atherosclerosis physically? And it depends on the situation. So if someone has a heart attack and that artery is fully blocked, it's really important to try and get that artery unblocked as quickly as possible. So if someone's having central crushing chest pain that's not going away after 10, 15 minutes, not going away with GTN spray, we say dial 999, get an ambulance out. If it's a heart attack, get straight into hospital. And then certain types of heart attack gets taken immediately for an angiogram to find the blocked artery, to then unblock the artery with what's called angioplasty. And usually we put a stent in the artery, which is a little metal scaffold to hold the artery up to its normal size. And that's to immediately restore blood flow, because the blood flow is cut off, damaging the heart. That can lead to death and heart failure. And if we can get that artery open, we can reduce the chance of death and heart failure. So in that setting, in an emergency heart attack, getting that artery open is really important. If you take it to the other extreme of somebody who's got an atherosclerotic plaque but doesn't have any symptoms, you will get zero benefit from interfering with the artery. You'll only get the harm risk of an invasive procedure. You won't have any preventative benefit or any symptom benefit whatsoever. And then you've got the people in between, who are the people that, yes, I get angina when I exercise, but I'm okay at rest. Well, to be honest, if the angina can be improved with medications and they're not having symptoms, the studies to date would suggest don't rush in to have anything physically done to the arteries unless there's a danger sign, like particular patterns on the ECG, particular patterns in where the narrowings are on CT, or if it's starting to affect the heart function. So some people can live with angina just on medications. Some people can live with atherosclerosis. They don't get any angina. Some people are getting angina even on medications. And in those people, it's perfectly valid for them to say, well, can you do something to improve the blood flow beyond this? And that's when things like stents, angioplasty can be helpful. Some people need a bypass operation for the same reason, because sometimes we can't always do stents. And then that takes you right through to the other extreme I mentioned, the heart attacks, where the pain is right there, right then, because of a blocked artery, where the primary thing, first of all, is get the artery open. there and then, and introducing the medications from that point if people are on medications already. So yeah, the treatment depends entirely on how the coronary heart disease is affecting the patient at the particular time. But statins, 100% statins. And the other thing I haven't mentioned is aspirin. So aspirin does not affect the plaque. It does not affect the atherosclerosis. It doesn't affect the blood pressure. And it doesn't affect the exercise of the heart. What aspirin does is make the platelets, which is a little component in your blood that's involved in forming blood clots to heal wounds. They make the platelets less likely to stick together and form blood clots. So, an aspirin is a very good treatment for preventing blocked arteries from blood clots. The downside of aspirin is it can cause ulcers in the stomach and bleeding. So, if everybody takes an aspirin a day, then everybody's going to be less likely to have a heart attack or a stroke, but everyone's going to be more likely to have a gastrointestinal bleed. So aspirin for everyone is not very helpful. Aspirin in the setting of a heart attack is massively important. So the first thing that the paramedics will do, or the 999 controller will do, is say to the person, take a 300 milligram aspirin if you've got it, because there's good evidence that if you take an aspirin at the time of a heart attack, you make a big difference to your risk of surviving or dying from the heart attack. So the humble aspirin is really important during a heart attack, less important for somebody who has chronic stable angina. But again, it's a spectrum. So if you have no symptoms or mild angina, you may not need to be on aspirin. If you're having a heart attack, you absolutely need aspirin. If you've had a heart attack or a stroke, you probably should always stay on aspirin or an equivalent drug. There's another one called clopidogrel or prasugrel or ticagrelor. These are all antiplatelet drugs that work on prevention of the blood clot element of what triggers a heart attack, but they're not affecting the atherosclerotic plaque. So they're a really important class of drugs. But my own view of aspirin is nowhere in it. For someone with coronary artery plaque who hasn't had a problem like a heart attack, the statins are really important because they will prevent the progression. Aspirin is less important because, well, certainly aspirin every day is less important because the evidence is not as strong. But I'd probably always say to that person, well, take aspirin if you want, or at least have aspirin in your house, because if you do have a heart attack, you want to be taking the aspirin then.